I might answer the one on the bone disease. So there is fantastic treatment for bone disease in cancers. The most common cancers that affect bones are prostate and breast cancer. So there's drugs that can strengthen the integrity of bone, prevent fracture, prevent pain. These are several 100,000 patient studies over a decade that show that these drugs work spectacularly well. One of them is called zoledronic acid, Zometa. It's an infusion given once a month by 15-20 minute injection. And the other more modern one is a subcutaneous injection given every 28 days called denosumab. The trade name's Xgeva. And a few side effects, but nothing minor or nothing major at all. So this is standard of care in those diseases. The companies have extrapolated into other solid tumor cancers. The studies aren't really powered to look at other cancers that affect bone. So you know what I'm going to say, neuroendocrine tumors are rare cancers, so therefore are these drugs extrapolatable to rare cancers? The answer is we don't know, but I think it's a very good idea to put patients like yourself, and there's other patients here, on such drugs for that reason.
Yeah, and I wouldn't question that, but I know some experts. There are two types of bone metastases, one that are stable and one that are slightly unstable when it's a little bit lytic. And I personally tend to put on, if it looks like it's lytic or a little bit unstable, that we'll use those forms of therapy. I don't ask permission, we just put them on it, like you say, an infusion. But if some patients are stable, got very stable and structured bone metastasis, they can do pretty fine with it. And I've got lots of patients with bony mets who haven't been on anything like that and they've done well. And they haven't had fractures from them. It's a rare occurrence in my practice anyhow, but I fully agree with it. I mean, if there's any question, we should just use them. And just on somatostatin before handing to, again, there are places, and Uppsala might be one, where I disagree with. When patients tend to progress and if they don't need somatostatin for symptom control, and they progress in one therapy, my standard therapy and lots of the centers of excellence in Europe would be to stop the somatostatin. In other words, there's two questions really within that. Is there any benefit of continue it if you've progressed on it? Probably not, in my opinion, if you in actual fact you don't need it for your symptom control. And for those other tumors, like you were saying, mentioned about rectum and other ones as well, if you're not really strongly octriscan positive and you don't have a lot of receptors, usually they're not going to work anyhow. These are the receptors for the drug. And if you've progressed on it, again, even if it was a reasonable option at the outset, then I would tend not to continue it. I mean, it didn't work, or it might have worked a little bit at the outset, and it's this Ki-67 that you're talking about, again, that was mentioned here earlier in the question. There are some tumors that are not sufficiently slow growing that the octreotide on its own will control it, and that there's some escape mechanism, and there's other tumor pathways within the tumor cells that's driving it, and it's not just being halted by the actual somatostatin analogs that you're using. And that's probably the mechanism. We don't have a really fantastic scientific answer for that, but it happens, fortunately not that frequently, but it happens, Colin.
Okay, I also have a comment regarding the hindgut, that for instance, you asked if they were included in a study, and actually they were included, some hindgut patients in the clarinet study, and they benefited from treatment. They were in the group who had a prolongation of progression-free survival for 18 months. But the benefit ends at some times, and possibly, as Dermot said, because the tumor or the metastases have increased the Ki-67 index. And then PRT is excellent. We have had many patients with rectal neuroendocrine tumors have responded to PRT. Yeah, but there are other options that have sort of been explored right now. We have treated patients with progression after conventional therapy with hindgut tumors with temozolomide, for instance. And there is a RADIANT-4 study that is not being published yet, but it was presented at the ESMO meeting, that colorectal neuroendocrine tumors had benefit from receiving everolimus. So that's another option. So that's, as long as PRT works, then after that there are other options. And I would also say regarding the bone metastases, it's also, we have the same policy in Uppsala. Some patients have sclerotic skeletal metastases, and those metastases are strong. There's no risk for fracture. whereas if they are lytic, we give the patients denosumab directly. It's a standard treatment in our patients.